From Microbe TV, this is Infectious Disease Puscast, episode 78, recorded on Wednesday, April 9th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I just made it to our recording today. My brain's a little fried, but hopefully we'll recuperate as we're talking. I tell my fellows that I apologize for having word-finding difficulties when I'm on service. So I will also apologize to the audience if I struggle today.
Well, I was recently listening to one of your febrile episodes, the one about the eye infections, and just thinking about all the anatomy and the different chambers. And It's great. Little plug for that. So.
Well, anything else going on with you, Daniel, before we jump in?
No, I think things in general are the way they are. It's interesting times we live in. That's that Chinese curse.
Yes. Well, let's talk about some fun stuff. So, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So, on to the literature, shall we?
All right, I have to say, I'm pretty excited about some of the articles we're going to be talking about this week, Sara. So
we got
call me a nerd, but we will start in our viral section. Remember to listen to TWIV, which is turned into This Week in Measles and Vaccine Preventable Diseases Updates. So listen to the clinical update and the deep dives. Actually, there's a little bit of overlap. I'm going to reference one of our deep dive TWIVs today, but I will start off with the article that got me quite excited, Demise of the Milwaukee Protocol for Rabies. This was published in CID, and the authors start by discussing that human rabies has a very high fatality rate, and there have only been about 33 well-documented survivors defined as survival at 6 months after onset of clinical rabies. And many have had serious neurological sequelae. I must say there's like a list of things that horrify me, and having seen patients with severe burns, rabies, this right up there. So here we read that after a young patient survived rabies in Milwaukee in 2004, the approach dubbed the Milwaukee Protocol has been aggressively promoted, I like the language there, as an effective therapy. The protocol has included therapeutic-induced coma, ketamine, ribavirin, and amantadine. And details of the protocol have changed over time. Over the last 2 decades, no subsequent detailed reports have documented evidence of efficacy. There have been at least 64 cases with failure of the protocol. And I remember when this first happened. So the authors here suggest that the time has now come to abandon the failed Milwaukee Protocol for the therapy of rabies and consider new approaches based on our current knowledge of rabies pathogenesis. So let's talk a little bit about this here. So I felt like this was worth a closer look, so I will recommend people go ahead and read this. But here we read that in 2005, I was a doctor back then, if you can believe that. I actually been in practice for years by then, so boy, am I getting old. But anyway, in 2005, a case report was published in the New England Journal of Medicine, and we all got pretty excited about this 15-year-old girl who was bitten by a bat in church. See, it is risky to go to church. She received no post-exposure rabies prophylaxis. I'm going to use this as an excuse, right? Easter's coming up, and what about the bats? And is it really worth it? All right. So she received no post-exposure rabies prophylaxis, developed clinical rabies with the presence of serum and cerebral spinal fluid neutralizing anti-rabies virus antibodies, received aggressive therapy, and survived with mild neurological sequelae. The patient received therapy that included the therapeutic, as we discussed, induced coma with benzodiazepines. They used midazolam, barbiturates to achieve a burst suppression pattern on the electroencephalogram, ketamine, and antiviral therapy with ribavirin and amantadine. Now, In 2018, Willoughby, he was the first author of that 2025 New England Journal Medicine paper. He claimed to have 18 survivors of human rabies with the Milwaukee Protocol.
18.
But there were no high-quality reports of survivors beyond the index case in Milwaukee, right? So he's saying he's got these cases, but where are they? Now, interesting, he has not claimed any additional survivors through the 6-year period ending in October 2024. There are at least 64 reports of failures of the Milwaukee Protocol. Apparently, the main proponent of the Milwaukee Protocol includes the claim of a survivor who likely never had rabies. This girl from California made a rapid recovery, never developed neutralizing anti-rabies virus antibodies. There's another similar case where, again, it appears the survivor never actually had rabies. The conclusion in this article suggests that, sort of an opportunity loss here, continued repetition of the Milwaukee Protocol in multiple versions over about 20 years has failed to show efficacy and has actually served to impede progress for the development of effective therapy for human rabies.
That's really interesting. I hadn't heard of that protocol before, but 18 undocumented rabies survivors out there?
Yeah, it's a little bit quote unquote fishy. At least these authors are suggesting that. So maybe some people will email in. Maybe Willoughby will email in. Maybe he's an avid ID Puscast listener, and we'll hear the other side.
Love it.
Okay. The article, A Natural Experiment on the Effect of Herpes Zoster Vaccination on Dementia, was published in Nature. This is actually getting a lot of press. I thought we would spend some time on this. I may even talk about this on the deep dive too, just get this out there as much as possible, but sort of a very pro-vaccine finding. But neurotropic herpes viruses, herpes viridae, such as chickenpox virus or varicella zoster virus, VZV, may be implicated in the development of dementia. So the idea, several ideas, but one idea is that the immune response or the virus itself may trigger the production of tau and other harmful substances in the brain. Here, they looked at the effect of the original live attenuated herpes zoster vaccination on the occurrence of the dementia diagnosis. And so I just want to point out, we're looking here at the original, not the Shingrix protein base. So we'll kind of discuss that a little. But the investigators took advantage of the fact that in Wales, eligibility for the zoster vaccine was determined on the basis of an individual's exact date of birth. And they were really pretty rigid here. So those born before the 2nd of September, 1933, were ineligible and remained ineligible for life, right? Whereas if you're born on or after September 2nd, 1933, you were eligible for at least, you were eligible to get this vaccine. So because of this policy, the percentage of adults who received the vaccine increased from 0.01% among patients who were merely 1 week too old to be eligible. So basically nobody was getting it, to almost half, 47.2. Notice that number, not quite half, so about half. Were just 1 week older. So that's really the difference. This birth date creates these two groups. So similar groups in this large database, except for this slight difference in birth. And I have to say, they go through everything. Did something change in the schools? Did something politically happen? Did some, thing else go on? So they observed that receiving the zoster vaccine reduced the probability of a new dementia diagnosis over a follow-up period of 7 years by 3.5 percentage points, or a 20% relative reduction. The protective effect was stronger among men than women. And remember, this is only half of the people, so this may be underestimating. We may really be seeing a 40% reduction in dementia. And I'll leave a link to the article. I'll also leave a link to the TWIV deep dive. You can either listen to that or watch that on YouTube.
Yeah, I feel like this has shown up in all my little news alerts. So I'm glad you included it. I brought one paper from Lancet Infectious Diseases. You guys know I try to grab CMV papers. This is an update. So recommendations from the 10th European Conference on Infections and Leukemia for the management of cytomegalovirus or CMV in patients after allogeneic hematopoietic cell transplantation and other T-cell engaging therapies. The prior publication is from 2019, so this is an update. There's been a lot of changes in this past, 5-ish years. Just for some general overview, they recommend weekly monitoring of CMV in the first 100 days post-transplant that, may be extended if they have other risk factors such as mismatched cord blood or haploidentical transplants, GVHD, and so on. But I think the biggest thing here is that letermovir is the recommendation for CMV primary prophylaxis to prevent CMV reactivation across the board for our CMV seropositive adult stem cell transplant recipients. They also have language in there about considering this for children as well. So if you look back in the 2019 one, I think there's like a little table that has ganciclovir, and some of the other options, and that's sort of been collapsed into they actually say the use of Valgan, ganciclovir, IVIG, or foscarnet as prophylaxis against CMV reactivation is generally not recommended. And then maribavir is highlighted for our resistant and refractory cases. As many people probably know, the pivotal trial came after these prior guidelines. And then they give the caveat about how maribavir has poor penetration into the eye and CNS. And then, CMV specific T cells could be an option if available for resistant refractory disease. And you could still consider combination therapy in these resistant refractory cases, although not the combo of maribavir with valganciclovir or ganciclovir. So I put the new figure, which is nicely color-coded for resistant and refractory CMV infection. That has it's kind of like a blue for the without known resistance mutations in patients who are refractory. There's an orange for UL97 mutations, and this kind of purple lavender for UL54. So folks I already saved it to my computer because I'm sure I'm going to reference it later. And as you probably picked up on the title, they do comment on, CMV infection and thinking about that in our patients who receive CAR T, so chimeric antigen receptor T cells, and those receiving bispecific T cell engaging antibodies. And so they have some general recommendations in there. There's still some places where, we're not totally sure what to do, in particular CMV immune monitoring. I pulled out the sort of general language here that the main applications of these CMV immune monitoring assays may include extending or shortening the duration of primary letermovir prophylaxis, withholding therapy for low-level viral loads, and trying to identify patients that might benefit from secondary letermovir prophylaxis. So very cool, nice update. Folks can save it to their computer so they have it to reference for the next time it comes up on service or in clinic.
All right. It's really gotten to be like a specialty unto itself, all this transplant stuff.
Well, I mean, with the CAR T and BITE and all these additional therapies, it's tough to keep up because it's so constantly changing.
Yep. All right. So I've got this next article, which, I think I'm kind of drawn to articles like this, but this is the article, Epstein-Barr virus exposure precedes Crohn's disease development, published in Gastroenterology. And this reminded me of that study in the military recruits where they looked at getting EBV and seroconversion and getting MS, right? Multiple sclerosis. And so here, this is more data from and you got to love the acronym, PREDICTS, the Proteomic Evaluation and Discovery in an IBD Cohort of Tri-Service Subjects study. So the PREDICTS study, where they looked at seroconversion in a cohort of healthy, active military personnel that were monitored longitudinally with linked serum samples. They observed CD patients, Crohn's disease patients, compared with healthy controls, had increased exposure to herpes virus 4, commonly referred to as Epstein-Barr virus. I would say pretty much referred to as EBV by just about everyone. When was the last time you told someone, oh, you got mono, it's probably just that herpes virus 4. Even your colleagues looked at you like you had two heads. But anyway, they observed that the Crohn's disease patients had increased exposure to EBV 5 to 7 years before diagnosis. And if you looked at this, 3 to 5 times more likely, 3.05 times more likely to develop Crohn's disease. And there's a nice figure they have where you can actually look at this exposure, and you look at exposures to different viruses. And really EBV, which they call herpes virus 4 in their table, really stands out. There's a little bit of a signal I'm seeing for HSV1, but not really. But so just to point that out. But really interesting stuff. I don't know. Are you as interested as I am, Sarah? Am I just a little overexcited?
Well, I didn't read this, so, but I mean, the concept that EBV does a lot of additional things I buy into, but I also feel like I need to look at it because a lot of people get EBV, and yeah, I will read further, Daniel.
Oh, okay. Yeah. No, I mean, this is, I think, sort of the magic of these seroconversion military studies, because you follow over time, you can see that, and then you go ahead and see sort of this linkage.
Well, also to specifically have the time frame of when someone has EBV infection, which I feel like we don't usually have the luxury of seeing that.
Yeah, I think this is going to be one of those situations where if we ever get an EBV antiviral or an EBV vaccine, then we'll see all this stuff after the fact, right? Like they get the measles vaccine. Not only did you see all the protection against measles, but suddenly like, hey, there's 50% reduction in kids dying of all kinds of stuff. Mm-hmm. And you see all these sort of secondary impacts. So like, what is it? The HPV vaccine and, reducing heart disease, by half. So pretty...
Yeah.
I'm looking forward to that, but let's move into bacterial. Be sure to listen to TWIM this week in microbiology. And I'll start off with the FDA on this last Tuesday when I was compiling this. They approved GSK's oral antibiotic gepotidacin for the treatment of uncomplicated urinary tract infections. So don't worry, you don't have to pronounce that. The drug will be marketed under the name Blue Jepa. I don't know. Is that any better?
Rolls off the tongue.
Just rolls off. Blue Jepa. So the approval covers female patients aged 12 years and up who weigh at least 40 kilograms and is indicated for uncomplicated infections caused by common bacteria. I like that. Uncomplicated infections caused by common bacteria, such as E. coli, Klebsiella, Citrobacter, Staph saprophyticus, Enterococcus faecalis. And according to GSK, Blue Jepa is the first new class of oral antibiotics for this indication in nearly 3 decades. So they're gonna launch Blue Jepa in the second half of 2025. It's a once daily drug taken for 3 to 5 days. It inhibits bacterial DNA replication by blocking 2 essential enzymes, topoisomerase 2 and DNA gyrase. And the mechanism is different from other antibiotics, which makes it effective against bacteria that are resistant to other antibiotics. And why did they approve it? Well, the approval is based on 2 phase 3 trials. Eagle 2, where Blue Jepa was non-inferior to nitrofurantoin. More than half of the Blue Jepa treated patients achieved treatment success as compared to 47% in the nitrofurantoin comparators. That's kind of tricky, right? Like a little more than half compared to a little less than half, but just put that out there. And Eagle 3 found Blue Jepa to be significantly better than nitrofurantoin, resulting in 58.5% success versus 43.6%.
I'll take some new UTI antibiotics.
Yeah, I'm looking for it. And will it be crazily priced, or will it be something that we can actually use? Fingers crossed.
Well, we haven't talked about febrile UTIs in children in a while. I pulled a paper from Lancet Infectious Diseases. Title's kind of long. Efficacy and safety of individualized versus standard 10-day antibiotic treatment in children with febrile UTI, abbreviated INDI, INDI-UTI, INDI-UTI. It's not as catchy, but it's fine. As I was reading, I just pictured like indie music background thinking about UTI, so maybe you guys can picture that. Oh, I'm not even done with the title. Okay. A pragmatic, open label, multi-center, randomized controlled, non-inferiority trial in Denmark. So we are going to talk about the results of this INDI UTI trial, which you heard most of the details in the title. It was conducted in 8 Danish hospitals. They took febrile children between the ages of 3 months and 12 years who had growth of a uropathogenic bacteria and assigned them 1-to-1 to have individualized versus standard 10-day treatment for febrile UTI. So this excluded children who would have known urinary tract abnormalities, that were having bacteremia at the same time, that had elevated creatinine, or that were immunosuppressed. And so that individualized group, they were allowed to stop treatment 3 days after adequate clinical improvement. So that would be potentially 3 days after fever subsided and there was clinical improvement, but they did have a minimum treatment duration of 4 days. So they could have 4 days plus, whatever was decided. And so the primary outcomes that they were looking at were recurrent UTI within 28 days after stopping treatment and the total antibiotic days. They had 408 patients who were randomized, so there was about 200 in each group, individualized versus standard treatment. The median antibiotic duration in that individualized group was 5.3 days versus, not surprisingly, 10 days in the 10-day standard group. The median age was 1.5 years old, and this was mostly 80% female patients. They found that recurrent UTI within that 28-day frame occurred in 11% of the individualized group versus 6% in the 10-day group. So that was 23 out of 205 people versus 12 out of 203 people. The total antibiotic days within that 28-day time frame was 6 versus 10. And for those who are curious, the most frequently used drug was amoxicillin clavulanate. So in this case, the children with febrile UTI who were assigned to individualized treatment had an increased risk of recurrent UTI, so 5.3 percentage points. And I'm pretty sure we talked about these old trials, but just for context, as a quick reminder, we've had the American Scout SCOUT trial, which compared 5 days versus 10 days of treatment in children with UTI. Those, about a third of them were febrile. They mostly received ceftonir. In that study, non-inferiority was not shown, but the authors concluded that the low failure rate with the short therapy suggested that 5 days was probably a reasonable option. That one I think we did talk about on Puscast. Mm-hmm. There was also the Italian STOP trial, which showed non-inferiority of 5 days compared to 10 days based on 30-day recurrence in children. Most of those kids were treated with amoxiclav, like this study. So this study is kind of consistent with SCOUT, sort of contrasts that STOP, but I guess the biggest question is, does it really help you solve the controversy? Here, non-inferiority was not shown, but there was reduced antibiotic exposure. So the average exposure to antibiotics was 4 days less than those who got, quote, individualized treatment. They had fewer adverse event days. And if you looked at the 100-day recurrence rate, there was non-inferiority shown. So 16% recurrence rate in the individualized group versus 14% in the standard 10-day group at 100 days. And then I'll just mention that 14%, so 4 of the 29 of the recurrences in the standard 10-day group were due to a club pneumo. So how do you interpret all this? I mean, I think you could argue that longer treatment can impact your intestinal microbiota, your urinary microbiome, thereby potentially selecting for bacteria more likely to cause recurrence or reinfection. Here we saw these late recurrences, some of which were with club pneumo. So maybe this selection pressure having less adverse events, does that balance out those early recurrences and kind of make the case for individualized therapy or not? I still, that's kind of my thought, is there probably is still, what's the best way for to say? Like, I still think that 5 days could be a reasonable option in certain kiddos. And, I think the bigger question of whether or not you could extrapolate this to adults, I don't know. That question is a little bit harder because I do think febrile UTI in kids is kind of a somewhat unique entity, but interested to see what people think. And I think it's nice that there's a couple things that you can talk about. I think it'd be a good journal club article for those who have to pick something coming up.
Okay. The article, Frequency and Severity of Myasthenia Gravis Exacerbations Associated with the Use of Ciprofloxacin, Levofloxacin, and Azithromycin. Here we have a retrospective review. This was, where was this published? I don't think I've noticed.
Let's
where
find
that was
out.
Published. Can you check that for me? But this is one of those things like on rounds, right? You're always
nerve.
like, where was it?
Muscle and nerve. That's pretty
interesting. Yeah, how did I end up there? But so here is this retrospective review performed on myasthenia gravis patients seen at a single institution between 2002 and 2022, so 20 years, who received Cipro, Levofloxacin, or Azithromycin. So we've got 365 patients, total of 918 episodes of antibiotic usage. 339 got Cipro, 187 got Levofloxacin, 392 got Azithromycin. And they're looking at frequencies of myasthenia gravis exacerbation following antibiotic use. So 2.4% for Cipro, 1.6% for Levofloxacin, 1.5% for Azithro, and then 1.9% when you look at it all of them together. Now, 6 patients had impending crises and 9 required rescue therapy. Now, for comparison, right, because this is one of those things we always say, oh, if they've got myasthenia gravis, there's all these antibiotics not to use. When they looked at amoxicillin, right, which is supposed to be that safe one, don't worry, the background was 1.3%. So really not necessarily seeing a lot of compelling data here for this warning that we promote.
Yeah, I feel like that's a very board internal medicine board question.
Interesting, and it may not even be true, which is always kind of a problem with board questions. You know, they're great, and we've been asking this forever. It may not be true, but how can you take it off because it's such a great discriminator? Well, it might be people just that are remembering something that's not true, which is really not what we're supposed to be doing when we take our boards. Yeah, we're supposed to be remembering things that are true. So. Pet peeve of mine, call it.
If only tested for things that were correct and that we should know. And then I think I'm rounding out our section here. I have another paper from Lancet Microbe, or I have a couple today, I think. This one's pretty short. The cost of blood cultures, a barrier to diagnosis in low-income and middle-income countries. This actually is a comment to a prior editorial called Rethinking Blood Cultures, which was published, I think, in January or February in the context of the blood culture bottle shortage and, just discussing over-reliance on single manufacturers. And so the authors here are pointing out about the availability of blood cultures in sub-Saharan Africa, which remains low, and that only 1% of labs that are able to conduct bacterial testing, and kind of added some context that even if that is available or there is a lab, that there are additional challenges that hinder use of blood cultures. And so they took a look at sharing the cost of a blood culture and other incurred healthcare expenses by surveying about a little over 600 healthcare professionals in low and middle income countries. They found that 95.7% of respondents indicated that the price paid by patients for blood cultures covered the cost of the bottles, the laboratory identification of the bug, and antibiotic susceptibility testing. At that point, about 53% reported using BD Bactec bottles alone or some combination. And then kind of the point of this paper was they found the median cost and calculated it among 66 low and middle income countries and found the median cost was over $15 in about 29% of the responding countries, somewhere between $10 and $15 and 9%, and then $5 to $10 in about 15% of countries. And in the low and middle income countries where the median cost was under $5, the respondents did indicate there were support from either donors or some sort of universal health coverage in the country. And then they also reported the cost incurred to healthcare facilities with kind of similar numbers. They reported it out, over $15 for 23% of countries, $10 to $15 for about 17%, and then another about 30%, it costs $5 to $10. They kind of use these because there have been prior discussions suggesting that the optimal price for a blood culture should be less than $5. This has all been converted to US dollars, by the way. It just really highlights that accessibility and affordability for both the patient and the healthcare system is important. And they add a note about the value of having a competitive market, which can provide solutions at more affordable prices. So I thought that was a interesting read. And I linked the original editorial as well.
I like
Oh,
the
and I
map.
forgot to mention, I have a little map here, where they highlighted the price range for the blood culture per country, and you can see the countries that responded. So folks, I think that actually is what originally caught my eye. So I was like, oh, what is this map? And then I pulled a paper from CID, Trends in Anaplasmosis Over the Past Decade, a review of clinical features, lab data, and outcomes. This was a retrospective cohort study of all cases of human granulocytic anaplasmosis identified by positive PCR at Mayo Clinic in Rochester. They had 465 cases, and I actually included, this one also has an image of a map showing the zip code distribution in figure 1. So hopefully folks can visualize that. They also provided this bar chart that showed the annual trend of cases from 2012 to 2022. And interestingly, there was a dip in 2018, pre-pandemic for kind of unclear reasons. But for other things that they noted, about 2/3 of these patients were managed in the outpatient setting. For the other third that were hospitalized, these patients were more likely to be older, so a median age in kind of 70, 71 or so, and more of those patients were immunocompromised, so 17% that were hospitalized versus 7% that were not. And then we learn about this triad of leukopenia, thrombocytopenia, transaminitis when you're taught about anaplasma. They observed that in only about a quarter of these cases, but when those three, that triad was present, it was associated with a risk of hospitalization. And they have a really clever Venn diagram figure, which I really like, that shows the distribution of that. There's a leukopenia circle, thrombocytopenia circle, and a transaminitis, and showing kind of the overlap if they had one, two, or all three features. And then kind of the last thing is they did look at co-infection, but didn't find that co-infection necessarily impacted mortality or hospitalization. So this is cool. I feel like we've talked about anaplasma a couple of times while I've been on service this past week, so this is a nice thing to look at. And I really like that Venn diagram, so people should look at that. It's figure 3.
It's interesting the way so many of the cases, right? The hotspot is like Western Wisconsin, but they're all ending up at the Mayo.
Yeah. Excellent. Okay. And then we're going to move to fungal infection. And I can update that The Last of Us Season 2 is coming out the 13th, which I think is Sunday. It's Sunday. Well, now the White Lotus is over for all of us to watch White Lotus. Yeah. So now you have something new to watch on Sundays. I grabbed 2 papers. This first one is from OFID, Cracks in the Curriculum, the Hidden Deficiencies in Fungal Disease Coverage in Medical Books. The authors attempted to quantitatively assess mycology content in leading ID and IM textbooks to try to identify gaps, see if there was outdated information. So they looked at books like Harrison's, Mandel's, Feigen and Cherry for peds folks out there. And they compared the content against current publications and guidelines. Interestingly, they also looked at the level of expertise in fungal diseases by essentially PubMeding the textbook chapter authors and assessing their history, which is a, I guess, valid but interesting way to judge expertise. You can find some of their figures which mapped the scores for coverage by disease. And so I think I brought in figure I forget which figure 1, which might have been mostly Mandel's, but basically they kind of mapped scores by disease, and the books could kind of score higher or lower for certain diseases. So Mandel scored highly for most, but weaker for crypto and chromoblastomycosis and tularemycosis. They not surprisingly found that ID books had more specialized coverage. So something like Harrison's had what they deemed inadequate coverage in 75% of diseases and in all topics. And I took a quote here that the lack of information might compromise education of students and updates of professionals. The authors also felt that there was an emphasis mostly on epi rather than other features such as prevention, and pointed to some topics they felt were missing. And so I pulled this last section. I'm just going to read it. To ensure that healthcare professionals are educated to handle the complexity of fungal infections in today's context, it is essential for reference materials to reflect best practices based on evidence, new discoveries, and latest guidelines. Considering the gaps in textbooks, relying on up-to-date guidelines and peer-reviewed articles can enhance medical education by providing more accurate and current information. This approach supports the provision of high-quality, safe, and effective patient care, minimizing risks and optimizing clinical outcomes. So I like the idea behind it, and like finding where there are gaps. I do think that a lot of modern learners are probably supplementing with, like they said, guidelines and things online. And hopefully digital education, like podcasts, we're kind of preaching to the choir if someone's listening at this point. But yeah, I don't know. What do you think, Daniel? The kind of color charts for their content and expertise is interesting.
Yeah, I like the color charts. What I'm most worried about, right, is they talk about how so much of when they do decide they're going to talk about fungal diseases, they're talking about epidemiology. And you and I have discussed about how much of that is actually not true. Like what they teach, like we realize that the epi is really wrong. So it seems like the only thing they're teaching is the stuff that's wrong.
well, outdated maybe.
I think it's wrong. I mean, outdated. Like it's not like it was right at some point. It's just they said that because they didn't know, and now that we know, we realize we were wrong. And so, at a certain point, when you realize you're wrong, you should stop saying that. So again, right?
It's interesting. They reference some other folks who've done. I didn't realize that this had been done in some other studies before, where folks kind of took different like bacterial illnesses and compared if they were sort of up to date. So in the meantime, because we all know that these textbooks can only get updated so often, folks can listen to Puscast. We'll do our best.
All right. You're much kinder than I am.
Well, this next one, speaking of something you 100% are not going to find in those textbooks, I learned about a new fungus today from this article in OFID. Oh, good luck to myself. Kazakhstania sleuthia fungemia, a case report and literature review on an emerging opportunistic pathogen in humans. This is basically a non-albicans Candida. It would have been known as Candida sleuthiae, but I learned from the paper the yeast genus Kazakhstania was first described over 50 years ago by Zubkova with the isolation of Kazakhstania viticola from fermenting grapes in Kazakhstan. So pretty cool. Fun little party info. But they described the first documented case of fungemia with this bug in a human, which was a man in his 70s who had a history of achalasia and gastroparesis and some complications requiring esophagectomy in a J tube that was malnourished, and he came in with sepsis and ischemic bowel and also had a pleural effusion. Was ultimately treated with micafungin. They did cover 2 other human infections where echinocandins and fluconazole were effective. And to close us out on the fungal section, my last paper is from CID. Plasma microbial cell-free DNA metagenomic sequencing for diagnosis of invasive fungal diseases among high-risk outpatient and inpatient immunocompromised hosts. Okay. This was a case control study. They used prospectively collected archived plasma specimens, as well as some data from the Aspergillus Technology Consortium repository to look at the diagnostic performance of microbial cell-free DNA sequencing, aka Carius, as a tool for diagnosing fungal infection. So there were 65 people with proven or probable invasive fungal disease included, and they had 65 controls without fungal infection. Among those with disease, Aspergillus was identified most commonly. That was 71%. Then Mucorales, 11%. The testing was highly specific, so 100% for proven and probable invasive fungal disease. So that, essentially lack of false positives is nice to know. And I would like to say is a nice contrast to our friends galactomannan and beta-glucan. The sensitivity was somewhere around, 50%. It varied based on disease status and pathogen. The sensitivity was higher if it was proven disease versus probable, 60 versus 37%. It interestingly was higher in those with invasive mucor, so 100% of those cases. Obviously, that high sensitivity for mucor specifically is exciting. It is a very small group. This is like 6 or 7 patients, I think, in the paper. But I will give my bias that I have used it in that exact scenario where we didn't have a speedy way or identification of something we thought was probably mucor, and it was identified on a Carius first. Acknowledging the limitations of everything, I will add the things that were nice. It was a mix of SOT and stem cell recipients, heme malignancy, and a couple other immunocompromised hosts. They did take a peek at whether there might be an association between neutropenia and the test coming back positive. They only had 10 cases that the patients were neutropenic, and there was no clear association there. And the other thing that we often talk about is that, the suspicion would be that if we wanted to get a test like this, cell-free DNA, that we would do it early, and that hopefully would increase the yield. They found that the sensitivity is pretty similar regardless of the elapsed time, which was interesting. But this was also a group of people where 1 in every 5 were outpatient at the time of collection. And, ultimately, if folks are more ill and we need to get prompt testing, we'll do that. But I thought that was a interesting point. And so, the author suggests that cell-free DNA sequencing, microbial cell-free DNA sequencing could be a potential way to reduce invasive sampling. Obviously, maybe in particular about mucor, but lots more for us to learn. And hopefully we'll have more and more studies or sort of bigger collaborative studies.
Yeah, I was thinking, I bet before I win you over to Fungitel, it will be replaced by better technology. But we got to get the cost down, right? Because this is like $2,000 a test from that one company that does it.
And getting it outpatient in those patients, outside of a study, unless it's different for other folks, is extraordinarily expensive. Yeah. So I don't even really see it as a option for our outpatients because the cost is just going to get passed to the patient, I feel like.
Yeah, I worry it kind of gets pulled out when everything else has failed and you're, already well down the road and you would have liked to have known this before. But when costs come down, right?
Yeah.
Then, all right. But wait, aren't we going to return to the time when we don't need to know the diagnosis? We say, just some kind of infection. And people will be happy with that, the good old days?
Yeah.
Yeah. Okay. Good. All right. Parasitic. Be sure to listen to This Week in Parasitism. I've got a few here. So, fatal case of splash pad associated Naegleria fowleri meningoencephalitis, Pulaski County, Arkansas, September 2023. This is from the MMWR. So here's basically it's a case report, September 1st, 2023. A previously healthy child, 6 months old, was seen at a Arkansas hospital, 3-day history of fever, vomiting, decreased oral intake, new onset altered mental status. A non-contrast CT of the head demonstrated ventriculomegaly, concerning for increased intracranial pressure. Empiric treatment for bacterial viral meningitis was initiated, patients admitted, lumbar punctures performed. They end up doing a bunch of testing, which is mostly negative Patient's condition worsened. And then on September 3rd, right, so this is the coming the 1st, now we're on the 3rd, they actually see numerous amoebic microorganisms consistent with Naegleria fowleri. So family members reported that the patient had played at a splash pad and pool in Pulaski County, Arkansas. They go ahead and they start treatment, but the patient's condition did not improve, and the patient dies on September 4th. So just for people not familiar with these splash pads, there are like these pads and the kids run around and the water shoots up. And unfortunately, this water is not always properly treated, as we're seeing here, not properly chlorinated. And that forced water can end up really shooting that amoeba through the cribriform plate and into the CSF.
That picture's pretty incredible. That you included.
Yeah, so I put in a figure there of actually you can see the amoeba. All right, and also sticking on amoeba, we have the MMWR notes from the field fatal acanthamoeba encephalitis in a patient who regularly used tap water in an electronic nasal irrigation device and a continuous positive airway pressure machine at home, New Mexico, 2023. So another MMWR on November 15, 2023, CDC was notified of a patient age 66 who had died approximately 3 weeks after being hospitalized for altered mental status and weakness. Symptoms progressed to include seizures, fever, respiratory and gastrointestinal complications. They see brain lesions on MRI, and at autopsy, histopathological evidence of this granulomatous amoebic encephalitis. And as mentioned, the patient had reported no recent recreational water, but regularly used tap water in an electric nasal irrigation device and a CPAP machine at home. And so January 4th, 2024, the CDC received the patient brain specimens. The diagnosis was made, and we have some figures here. We can actually see the histopathology. They detected this also in culture from the electronic nasal irrigation device and in the water from the patient's CPAP machine. So, all right, and I will just finish off our parasitic section by encouraging people to use their free article access to read the really nice review article, Malaria in the New England Journal of Medicine. Not open access, but you get that free article access. And apparently we learned from, I think Ellen Dove, that if you like clear your history or your cookies or something, you can like keep getting multiple reads. I think that's dishonest, but I've just heard him say that.
It is pretty cool that there's a section on malaria vaccines and monoclonal antibodies now in the review.
That is exciting. Yeah, I'm actually writing a book chapter. I don't even know what book it's for. I have to talk to Chuck Nosh about which book it's for. But yeah, we're going to be talking a lot about the malaria vaccines, which there was a huge, just because we've got the nerdy crowd with us, the huge rollout of the malaria vaccine in Uganda. So very exciting.
Yeah, very cool.
All right, and I'm going to finish this up with the last miscellaneous. You made it this far. You're going to make it. FDA grants marketing authorization of first home test for chlamydia, gonorrhea, and trichomoniasis. If only we were recording on a Friday. This is the first diagnostic test for chlamydia, gonorrhea, and trichomoniasis that can be purchased without a prescription and performed entirely at home. It's like an infomercial. The test is intended for females with or without symptoms and delivers results in approximately 30 minutes. So this is the Visby Medical Women's Sexual Health Test, single use at home. They got a collection kit, self-collected vaginal swabs. They got this powered testing device that communicates securely to the Visby Medical app, assuming that goes on your phone. In individuals with or without symptoms, the Visby Medical Women's Sexual Health Test correctly identified 98.8% of negative and 97.2% of positive chlamydia trichomonas samples, 99.1% of negative and 100% of positive Neisseria gonorrhea samples, 98.5% negative, 97.8% of positive Trichomonas vaginalis samples.
It's very cool. Well, that brings us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can grab the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. Grab it with your favorite podcatcher or on YouTube. And then make sure to, I wrote it all, subscribe, like us, ring the bell, and leave comments. All right. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. And if you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or parasiteswithoutborders.com and click on the donate button.
I'm Sarah Dong. You can find me at Sarah Wynn Dong or Febrile Podcast on Blue Sky or febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.